Let's get right into it. Today, we're stepping into a high-stakes, hyper-accurate world that touches literally every single one of us, yet it operates entirely behind the scenes. We're talking about the fascinating mechanics of medical diagnosis coding. In this explainer, we're going to unpack exactly how medical coders act as data detectives. How do they translate complex human health conditions into highly specific, globally recognized alphanumeric strings? Specifically, we're going to focus on the core of their job, exactly how coders assign accurate diagnoses. Let's dive in. There's this massive tension in the environment these professionals operate in every single day. As certified professional coder Kathy Bukta points out, the pressure to improve medical revenue is a constant in today's workplace. But coders have to remain absolutely focused and firm. Why? Well, because every single code they assign dictates exactly what an insurance payer is going to be billed. The documentation in the medical record has to perfectly support every single claim. There's zero room for guesswork. So, that brings us to the core mystery of our explainer today. How exactly do they pull this off? How do these professionals take a physician's messy, highly complex, and often subjective medical chart and turn it into one undeniably accurate code? How do they make sure a hospital gets paid fairly without ever crossing the line into non-compliance? Section 1, the Healthcare Fraud Squad. To answer that question, we first really need to understand the true identity of the people doing this work. A medical coder is way more than someone just doing data entry. They abstract information from the patient record and combine it with a deep, deep knowledge of coding guidelines to optimize payment. And that word optimize is absolutely crucial here. In fact, coders are often respectfully called the fraud squad in the industry. Their ethical duty is to optimize the revenue a physician legally deserves, but they must never maximize it by inflating claims. They strictly code only what is explicitly documented. They are literally the gatekeepers of healthcare integrity. Section 2, Navigating the Code Sets. Let's look at the tools of their trade and open up the massive rulebook these detectives used to crack the case. The primary code set for medical diagnoses is the ICD-10-CM. That stands for the International Classification of Diseases, 10th Revision, Clinical Modification. Now, the base of this system is maintained by the World Health Organization, but that CM part, the clinical modification, that's developed specifically for use in the US by the National Center for Health Statistics. It is a staggering system. It's meticulously designed so that virtually anything that can go wrong with the human body has a specific, unique code. And the sheer precision of this system, it's mind-boggling. Diagnosis codes in the ICD-10-CM can be up to 7 characters long, and this really illustrates how strict the system is. If a category requires a 7th character to denote, say, the type of encounter, like an initial visit versus a subsequent one, and you only provide 6 characters, bam, that code is completely invalid, rejected flat out. Every single character has a distinct, mandatory purpose. But wait, what happens if a code requires a 7th character for specificity, but the base code itself is only 4 or 5 characters long? Enter the placeholder X. It's basically a genius structural hack. Coders have to use X to fill in the empty spaces to maintain the integrity of the code. This is what allows the WHO and the CDC to expand the code set in the future without breaking the whole existing structure. It's brilliant system architecture, and coders have to follow this flawlessly. Section 3, the two-step search rule. So how do they actually find these highly specific codes to assign those accurate diagnoses? Let's look at their investigative method. There is a mandatory, completely non-negotiable sequence every coder follows. Step 1, you locate the main condition in the alphabetic index. Step 2, you take that code and verify it in the tabular list. Think of it like this. The alphabetic index is the map pointing you to the right neighborhood, and the tabular list is the exact house address, where you confirm all the specific requirements, like those 7th characters we just talked about. And the official guidelines do not mince words here. They say, never begin searching initially in the tabular list, as this will lead to coding errors. Period. Why is this rule so strict? Because the alphabetic index actually contains descriptive words and synonyms that the tabular list just leaves out to save space. If you bypass the index, you might grab a code that looks right in the tabular list but totally misses the critical medical nuances. You always, always trust the map before you check the destination. Section 4, Inpatient versus Outpatient Rules. Now, if you thought the coding rules were exactly the same everywhere, prepare to be surprised. The coding rules literally change depending on where the patient is sitting. Let's compare a hospital, an inpatient setting, versus an outpatient clinic. For inpatients, coders assign accurate diagnoses by determining the principal diagnosis. That's the condition established after study to be chiefly responsible for admitting the patient. But over in an outpatient clinic, the rules change. There, they code the first listed diagnosis, which is the condition chiefly responsible for that specific short visit. And check out this contrast when dealing with uncertainty. If a patient is admitted to a hospital to rule out pneumonia, the inpatient coder actually codes pneumonia as if it were a confirmed diagnosis. Why? Because the massive hospital resources used to run tests and monitor that patient are averaged across their entire stay, whether they actually have pneumonia or not. But in an outpatient clinic, if the doctor says probable pneumonia, no way. The coder is strictly forbidden from coding pneumonia. They can only code the confirmed symptoms, like the cough and fever. Same patient, same symptoms, completely different codes. Section 5. The impact of accuracy. Let's zoom out a bit and look at the ripple effect of this precision.
It is super easy to think of medical coding as just a billing mechanism, right? But the data generated by this fraud squad actually builds the foundation of our entire global healthcare infrastructure. Sure, it facilitates payment, but it also evaluates how facilities are used. It studies the true cost of healthcare. Researchers use this exact data to measure quality. Public health officials use it to predict future health trends and plan where to build new facilities. Every single time a coder assigns a code accurately, they are feeding a vital global database.
To put this into real-world perspective, anytime you watch the news and hear a reporter cite the number of new COVID-19 cases or an outbreak of measles or Zika, you are looking directly at the results of diagnostic coding. The fraud squad doesn't just protect hospital revenue, they protect the absolute integrity of our global morbidity and mortality data. Without their strict adherence to those complex rules, the CDC and the WHO would be flying totally blind during a crisis. So, as we wrap up this explainer, I want to leave you with something to think about. Every time you visit a doctor, get a lab test, or stay in a hospital, you're generating an intricate story. What invisible string of alphanumeric codes is currently attached to your own medical history? And, knowing what you know now, isn't it kind of incredible to think about the quiet, highly ethical detective work happening behind the scenes to make sure your story is told with absolute perfect accuracy? Thanks for exploring this with us today.